بسم الله الرحمن الرحيم. Assalamu alaikum wa rahmatullah. In the name of Allah, peace upon all of you everywhere. Really, we are honored to conduct this great meeting on my room, Hussam Ziada Grand Round, which is interested in the field of anterior segment surgery, especially the refractive and the cataract. I'm so proud and so honored today to have in this meeting an international experts and speakers in the field of refractive surgery, whether laser-based or lens-based. And so let me to introduce my honorable guest and teacher, Dr. Mazen Sinjab, consultant ophthalmic surgeon, Medicare Eye Center and Hospital in Dubai. Actually, he is a very well-known person, so I cannot give him the expressing words he worths. But I think it will be expressive to say that all of us got the all informations and the all knowledge about the refractive surgery from his guiding books. I cannot forget the step-to-step guide for Pentacam interpretation. It's wonderful and guiding book, and the other books and the other lectures by Dr. Mazen Sinjab. Everywhere, all of us are learning from it, are getting the informations, are getting the guidelines from his knowledge. Thank you, Dr. Mazen, for your time and for your participation. And I know that you are quite so busy in the different webinars. And so I'm thanking you gratefully for giving me the time. Especially, I know that the time in Dubai now is late. Also, I am honored to have in this meeting one of the leader women in ophthalmology, Dr. Bonnie Henderson, cataract, cornea, and refractive consultant. Is a clinical professor of ophthalmology, and she is the past president of the American Society of the Cataract Refractive Surgeon, Boston, United States. Really, Dr. Bonnie Henderson is a brilliant teacher and professor. We were talking all the time about the ophthalmology and about the coronavirus too, but actually before being locked down, but Bonnie is not in Boston. Every day when I was talking to her, she is in different country, all over the world, in Africa, in Asia, in Europe, in Latin America, everywhere she is conducting the knowledge and the experience and the teaching. Thank you, Dr. Bonnie, and really I'm honored to have a very big and brilliant names like Dr. Mazen and Dr. Bonnie today. Also, I am honored to have today my dear colleague, Dr. Akram Al-Jazzar, cataract cornea refractive consultant and lecturer of ophthalmology, Al-Azhar University, Damietta branch. Thank you from all my colleagues who are attending this meeting. And let me to introduce Dr. Mazen Sinjab. He will start talking about the all basic parameters and the workup measures for the Phakic IOLs. And then we will go to the strategies to decrease the post-operative surprises with Dr. Bonnie, and we will discuss all together the commonly asked questions and important points needed for getting the excellence of the Phakic IOL implantation and also the refractive lens exchange. So I may ask Dr. Mazen to start his presentation. Please, sir.
Thank you, Dr. Hussam, for this kind invitation. I'm very happy to be among such eminent speakers. And what I'm going to do now, inshallah, I'm going to present my presentation into two parts. The first part is the Phakic IOL workup, and the second part is the, let's say, refractive lens exchange workup. I would prefer to do so. So when I present the workup of the Phakic IOL, then we will go into discussion with you all together, and then we can move after that to the second part. What do you think?
Okay. Yes. Yes.
Yeah. Can you see my screen now?
Yeah, clearly, yeah.
Great. Now, regarding the lens-based refractive surgery, we know that it consists of two parts, or two kinds, the Phakic IOL implantation and the refractive lens exchange, which I hate, actually. Now, let's start with the one that I love, which is Phakic, that I look for when I do the workup for the patient. Starting with the age that I look for when I do the workup for the patient. Starting with the age, of course, I don't do Phakic IOL when the patient is above 45, and I would be happy to hear the comments from the speakers about the cutoff age when they do this for the patient. Now, the second thing is the refractive error. Of course, we have to determine the refractive error by cycloplegic refraction, PMT, and so on. But what I mean by refractive error here is that I don't do Phakic IOL unless there is a reasonable refractive error to open the eye and put a foreign body inside. So usually I do the Phakic IOL when LASIK cannot be done and the refractive error is above 4 diopters, spherical equivalent. Regarding the posterior corneal astigmatism, we have to take it into consideration, especially when we are planning for toric Phakic IOL. So, and this always we have to provide the manufacturer by the true K readings taken by from the total corneal refractive power. And usually we look at the K readings at 3 millimeters, as you see in this slide, but we have to adjust the settings to be ring. If you look at the upper part of this screen, you will find that there are two blue arrows pointing at ring and apex, because there are other options like zone, pupil. So we have to choose ring, apex, and we have to choose K1, K2 in order to display the K readings and the total refractive power. And we have to provide the manufacturer with this, especially when we are planning for toric IOL. Now, if we don't have the pentacam, that screen was for the pentacam. If we don't have the pentacam, and for example, we have Cyrus or similar one, which is the MS39, there is something called the mean pupil power, which is equivalent to total corneal refractive power. And you can choose the zone that you would like to have the numbers. So you can choose the 3 millimeters, 4 millimeters, 3.5, however, but usually the standard is 3 millimeters, as you see, and you can take the average K readings. We come to the anterior chamber parameters. We have to look for both the internal anterior chamber depth and the external one. The internal one is important for to do or not to do, while the external one, which includes the corneal thickness, this is what we have to send to the manufacturer when they want to calculate the IOL power for us. Regarding the internal one, to do or not to do, usually in general, let's say that in the anterior chamber Phakic IOLs, at least there must be 3 millimeters of anterior chamber depth, while for the posterior chamber Phakic IOLs, there must be at least 2.8 millimeters. And in both cases, the anterior chamber angle should be more than 30 degrees to avoid any complications. We come to the corneal tomography. Corneal tomography is very important, of course. That's not because we don't do Phakic IOL in irregular corneas. We can do, of course, we can do even toric IOLs in case of keratoconus when they are indicated. Of course, there are special parameters for that. But corneal tomography is very important so that we can predict the results. We can tell the patient that your cornea is irregular, so the quality of vision will not be optimum. So this is important in order to predict the visual outcomes. Even we can do the phakic IOL in post-laser vision correction, such in this case. This is post-myopia. We can implant phakic IOL in case of residual refractive error. This is a case of post-astigmatic laser refractive surgery, and we can implant as well. This is a case of post-hypermetropic treatment, and we can implant as well. So all of these corneas are irregular, but this is not contraindicated for the phakic IOL, but by this, we can tell the patient that the quality of vision will be like this or like that. We come to the specular microscopy. It's very important to study three things in the specular microscopy. The first one is the cell count. We have to, let's say, there must be a minimum cell count according to age. For example, if the age is in the 20s, then at least 2,600 cell per square millimeter should be available. And if the age is in the 30s, then at least 2,400 cells should be available. Hexagonality is the second factor, and the normal hexagonality is at least 60%. So it should be more than 60%. If it is less than 60%, especially if it is less than 50%, then we can say that there is a risk of doing the phakic IOL. The polymygetism CV index, the cutoff value is 40%, so it should be less than 40% in order to say that it is safe to go for phakic IOL. Number 7 is the sulcus to sulcus, or white to white, or scleral spar to scleral spar, which is a new parameter. Now, why all these parameters of measurements? Because in the posterior chamber phakic IOLs, the phakic IOL is implanted in the sulcus. So the sizing should be as much accurate as possible to avoid complications, because we know that if it is too tight, then there will be maybe pupil block, maybe there will be glaucoma, and if it is loose, then there will be a touch with the lens and cataract development. So the ideal volt, which is the distance between the posterior surface of the phakic IOL and the anterior surface of the crystalline lens, this is called the volt. It should be between 300 microns and 600 microns. This is the ideal one. Now, regarding the white to white, of course, the usual or the normal white to white measurement is between 11 millimeters and 13 millimeters. We can use the caliper, which is a primitive way, of course. We can use the corneal tomography, and we can use the IOL calculation optical devices. Of course, the sulcus to sulcus is more accurate than white to white. And if we want to measure the sulcus to sulcus accurately, we have to use the high resolution or high definition ultrasound biomicroscopy. And we have to know that there is no 100% accurate correlation between white to white and sulcus to sulcus. So we cannot predict the sulcus to sulcus based on the white to white. In addition, that sulcus to sulcus is more accurate if available. Now we come to the scleral spar to scleral spar. Now this term is used in the MS39, which is the OCT-based tomography, which gives the measurement which we can use actually very accurately in sizing of the phakic IOL. But what is the scleral spar to scleral spar? Actually, it is an optical measurement, not a direct measurement of the distance between scleral spar in the horizontal slice of the OCT. Now, as you see here, I used the direct measurement of the scleral spar to scleral spar, and it shows almost 12 millimeters. While we can use in the same machine what is called the optical distance. I click on the other one, which is called the define index, and I put the index of refraction of the aqueous humor, which is 1.336. And then I do the measurement. And of course, we will have a more accurate measurement, which is a 12.25, which is very close to the that one which the machine gives. So actually the scleral spur to scleral spur that the MS39 give us is an optical one. So we depend on this number and no need to measure it by the caliber on the OCT. By this, I will stop. This is the workup for the Phakic IOL, and I will leave the microphone for the other speakers. Okay, Dr. Hussam, where are you?
Yes, I'm here. Okay, you just was muted. Thank you, Dr. Mazen, for this very informative, guiding, and simple presentation about the workup. Then, Dr. Akram, I watched you while we were writing questions. Then come with it.
What about the youngest age to be implanted, Dr. Mazen, regarding the age of a child?
Well, for me, the youngest age that I implanted Phakic IOL was 14 years for high anisometropia.
Can I implant with lower age, like 7 years?
Well, personally, I don't do. Personally, I don't do.
In cases of unilateral cases of anisometropia with amblyopia?
Anisometropia.
Yeah. Personally, I do not. I don't dare, actually. I dare not.
Okay, but you have any concerns about that?
No, not actually. And even I don't know whether there are some studies supporting this. I'm not aware of this.
Okay. About the ICL, there is my colleague, Dr. Al-Katib from Alexandria University. He conducted a study about that. ICL in children with anisometropia. I have conducted a study about that, but with the cornea refractive surgeries, not ICL. He showed his paper or study about that in I listened to him in some conference about this point, and he said that the results was excellent, provided that all measures or all conditions are provided in such a child.
Mm-hmm.
Yeah. Okay, about this age, but and Dr. Mazen, he said that he doesn't refuse, right, Dr. Mazen?
Yeah, I don't refuse, but I don't do.
Yeah. Okay. Well, and you said that the youngest age is 14 in case of hyperopia, not in myopia, because it's not stable yet.
Anisometropia. It was high anisometropia.
Anisometropia, yes.
Yes.
Yes. Okay. Dr. Bonnie.
Yes.
Okay. Wow. What's your opinion on that?
So I don't have as much experience as Dr. Mazen, but in the US, I think we're always worried about legal action. And so people are more wary of putting it in younger children just because of risk of lawsuits. I think that most people will wait until age 21, unless there is a specific reason, like Dr. Mazen was saying, that anisometropia is a good situation where I think it's reasonable to consider. In younger children, we worry that the patient may rub their eyes or cause some trauma to their eyes because they're still growing and they're in the stage of life where they're very active. So we worry about traumatic damage to their eyes. So I think that's one of the biggest worries. And then, of course, we want to make sure that the refractive error is stabilized. And we know that in their late teens and even up until their early 20s, sometimes the eyes do change quite a bit. So in an ideal perfect world, I think that we wait until the eyes stabilize. But, I agree with Dr. Mazen. That's an excellent point where each specific case has to be considered. So in a particular patient where they really need, and they have an anisometropia, and they really need to have some type of surgical solution to the anisometropia. I think a phakic IOL is very reasonable, especially if the patient is compliant. You know, if the patient is not controlled, they're crazy, they're running around. Sometimes my children were like that. It's harder to put in an intraocular lens in a patient that you're worried that they will not listen to the post-op instructions.
Okay.
Yes, Dr. Hassam, I
Yes.
agree with that. I agree with Dr. Henderson. The issue why I dare not is actually legal, because we don't have medical legal support when any complication occurs. This is why.
Yeah. Okay. Yeah, it's medical legal wise.
Yes.
Yeah. Okay. But scientifically, about the knowledge, if you have a patient or child with an anisometropia, which is so far from the corneal laser refractive surgeries,
yeah,
and still younger than the legal age,
yeah.
what would you do if you were in this situation?
Yeah, of course, medically, okay, or scientifically, we can go for that, no problem. Since if we are going to,
there is no consent. There is no consent for that. There is no legal consent for that. If you have to do
medical legally,
yeah.
we don't have a support, so
Yes.
I don't do.
Yes.
But scientifically, I don't know what is the age where the white to white does not change, stops changing.
Yeah.
So, for example, if you do for 6 years old, what about the white to white in the future after 4 or 5 years?
Actually,
is it going to change? Yeah, of course. So maybe the phakic IOL will start moving, and this will cause cataract. So we have to consider such things as well.
Yeah. Okay. Okay, Dr. Akram, we have another question.
Which is better, Dr. Mazen, from point of view, the IBCL, the Indian one, you have an experience with it, or Vision ICL?
Till now, I don't have an experience with the IPCL. No, I don't have. My experience is with the ICL, so I cannot compare. But as far as I know, according to what I see on the in the webinars, what I hear in the conferences, the experience with the IPCL is good.
Yeah.
According to my colleagues.
Really, according to my work and experience with both, it's okay. It's not muchly different. There is a question from our participants regarding the parameters preoperative like white to white. What's the question, Dr. Amr? Very nice, illustrative. Thanks, Dr. Mazen. Lens rise has a role here, Dr. Mazen. Dr. Rami is asking you. Lens rise,
yeah,
has a role here.
Yeah, this is why we maintain a vault, because there will be a lens rise by age, so there must be a minimum vault in order to avoid the touch in the future. And by this, I would ask Dr. Hassam about the studies that you said. One of the colleagues in Egypt did a study about phakic IOL, particularly the ICL in young children. So what was the length of the study?
The follow-up time, 1 year, just 1 year after the surgery.
Okay, actually we have to wait at least 5 years. We have to have at least 5 years of follow-up in such studies in order to see what will happen regarding the white measurements, the sizing, let's say in general, the sizing of the ICL, and regarding the lens rise, such things. What do you think, Dr. Henderson?
I agree. I mean, I think that especially in this age group, if this was an adult age group, a shorter follow-up is fine. But in a younger age group, I do think a longer time frame, longer follow-up is really important to know what the long-term complications, long-term effects will be. I agree.
Okay, actually, my professors and my dear colleagues, the problem here is the loss of the sight, because if we didn't do something for this child in the certain and the valuable time, and the suitable for the situation itself, which is the amblyopia, we will lose the options in the future. Really, we are stuck in this problem here about the medical, legal, the scientific, and also the strangling all the time with the pediatric ophthalmologists. They are refusing the surgical solutions for the anisotropia with amblyopia, despite the adequate time plan for the glasses and patching. There is no results at all with both. So if we are insisting to stay with it, we will lose. I have a lot of patients in the clinic coming after the age of 16 to do LASIK surgery in an amblyopic eye. So when I asked about the previous history, they always say that the doctor told us not to do anything before the age of 18 because it's the legal age for refractive surgery, either laser or Phakic IOL. But in such time, there's no improvement, there's no correction. So for the all today, we have to find a solution, but away from the jail, not to be admitted in the jail at the end.
Yeah. Yeah.
What is the contact lens usage in your countries? Is it something that a lot of teenagers can be successfully taught how to use, and not even teenagers, maybe younger, 8 years old to 10 years old?
Perfect point, Bonnie. But actually, when I said that I will jump to the refractive surgery, I mean that the contact lens either tried or not suitable at all because of the activities, the daily activities of the child, either to lose it, to miss it, and he will not. The child will not care about the loss or the eye rubbing, the dust and the sweating and the all daily activity for the child's outside during their days. So when I find that this child is candidate for the contact lens, actually I have no problem. I will complete with the contact lens, and already I have a lot. But somewhat it's more suitable for the girls, not the boys, especially the age beyond 12 years. They may keep it for a time until reaching the stability and the legal age, especially after the truthful information from Dr. Mazen about the age of 20. When I ask someone from my colleague about the age of 18, he says, Dr. Mazen Sinjab said, after the age of 20, don't do before the age of 20 years. Okay. What's your opinion, Dr. Mazen?
There's a question. When you consider extracting or exchanging an eye cell?
Extracting, well, it is a very big question.
Or exchanging.
I will take it from you, Dr. Akram. We have a part of presentation today about the explantation. Please, we may save this time and postpone this question, please. We will discuss it in our video showing the explantation and the indications for it.
Okay, nice.
Excuse me. Yes, finally about the specular microscopy. I asked you, Dr. Mazen, a question and you called it a clever one, but actually I still thinking in the all answers about it. What's the reason? What's the cell count and the polymorphism, which will push you to expand IOL? It's just part of the workup. And what's your recommendations about the follow-up? Do you follow your patients up by the specular microscopy after the Phakic IOL? All the patients?
Yeah, a very good question. Actually, I follow by specular microscopy whenever I have some features of corneal thickening, when I start seeing corneal thickening on the slit lamp, or for example, the CCT, when we do the autoref, there are some autorefs with pachymetry. So whenever I feel that the central pachymetry is getting out of the normal range, then I send the patient for endothelial cell count. This is one point. Now, my value where I have to extract it is 1,500. I don't wait for the 1,000. Whenever the endothelial cell count reaches the 1,500, I have to remove, even if the cornea is still clear.
Yes, okay. Thank you very much. What's the normal rate of cell loss in the normal population with no surgery?
Actually, I showed that in one of the slides. It showed like
2 to 5% per year?
No, 0.6%, 0.6% per year, which is almost 100 to 500 cells per year.
Yeah, 0.6% per year.
Yes.
So it will be considered to be an alarming sign if it's more than 1 or 2%?
I don't monitor it like this. You can say that like this if you are monitoring every year, and then you can make a comparison. Now, the comparison is not always accurate, because we have to depend not only on the automated counting of the machine, because it's very much affected by the transparency of the cornea. Sometimes we need to make it manual. So there are some error factors. For me, whenever I reach the 1,500, I have to extract the ICL.
Yeah, okay. Do you depend all the time on the IOL master or the manual measurement of the white? Or both
no,
of them?
Of course. No, but now because I have the MS39, I'm depending on the scleral spar to scleral spar.
But if we don't have?
Yes, IOL master, of course. It's more accurate than the white by the caliper.
MS39. It's Mazen. It's for Mazen Sinjab 39.
Yeah, the initials of Mazen Sinjab.
Okay. Actually, there's an important question about the sizing of the. We are talking about the ICL mostly. About the sizing, if you measure the white to white, and you will get a lens which is not actually the same white to white. What to do, and what's the difference which could be accepted? If the white to white is 12, and you got a lens of 12.5 or 11.5 or 13.
I think 0.5 millimeter within 0.5. I think this is
more or less. More or less.
Yes, within 0.5 is acceptable, but more than this, I think no, it's not.
More or less.
Yeah, more or less. Yes.
No, I don't mean that. 1.5. So sorry, 0.5 more than the ideal or less than the ideal?
Both.
Both. Okay. Within 0.5 plus or minus. You mean that?
For example, if I have 12 millimeter, if I get 11.5, or I get 12.5, 12.25, 11.75.
Yes.
For me, it's fine.
Okay.
But more than this, no, out of this range, it is not acceptable.
You will not afraid of the overcrowding with the more?
Within the 0.5 difference, I don't think there will be significant crowding. Within.
Okay. Especially if we have a good anterior chamber depth, more than 3.
Yes,
but
3 and above.
But if we are dealing with a borderline case like 2.9 millimeter anterior chamber depth, you will consider that too or not?
For the posterior chamber, for the ICL, I implant whenever it is 2.8 and above.
Yeah.
All right.
Okay.
But for the anterior chamber, the artisan, for example, I implant whenever it is 3 millimeters and above.
Yeah. Okay. Perfect.
For
Yes.
the ICL, 2.9 is not borderline for me. 2.8 is the borderline for me.
Okay. But your decision will be changed if you are borderline?
Well, actually depends on the structure of the anterior chamber, of the anterior segment of the eye. Of course, I have to do like the OCT to see the angle to see. If the angle is below 22 degrees, then there is a risk, of course. But I usually do peripheral vitrectomy with always I do the peripheral vitrectomy. I do 2 cuts.
Peripheral iridotomy or
Iridotomy.
Yeah,
Yes,
yeah.
by the vitrector.
But
By
we,
the vitrector. Okay.
With the vitrector.
but we can do a vitrectomy too. It will widen the anterior chamber. It is joke.
Sorry?
It's just a joke. It's such a joke. We will do anterior vitrectomy to take the lens down and increase the anterior chamber depth. It's a great idea, new idea now.
Yeah, innovative.
Yeah. Okay. Thank you.
I would like to hear Bonnie's opinion
okay.
regarding the sizing. What are your limits regarding the sizing? When do you say that, no, this is not acceptable, I have to take off the lens? The answer to question of Hussam.
Sure, it's very similar to your answer. You know, I think that about half a 0.5 is also a very good guideline. I think it's also specific to the case. So, for example, if the patient is doing well, they don't have any changes clinically, symptomatically, they're not getting inflammation, the cornea looks stable, their vision is stable, things are good. Although I was worried that the initial sizing was not correct, I think that I would leave it alone. But if I was worried about the implantation, it was too small or too big, and post-operatively I'm noticing inflammation, or their corneal, the specular microscopy is going down, or they're getting blurry vision, something is happening, then I'm definitely more concerned about it, and I would think about removal. But I think your guidelines that you're discussing is a good guideline, and a lot of it, like I said, has to do more with an individual case. Similarly, with the specular microscopy, I think 1500 is a very good guideline as well. And again, similarly, case by case, it depends on how the patient is doing and the rate of change. So if I was worried and I see that the rate of change, the rate of decrease in the cells is quite rapid, then I'm much more concerned. If it's been over 10 years and they really haven't had much of a rate of change and it's been a very slow degradation, then I would be less concerned. And then also if there was some incident, maybe they were in a car accident or something happened where I thought that there was some traumatic event, whether it's a one-time event or whether it's ongoing, maybe they have bad allergies and I know their eyes and their sleep, those types of factors would probably come into play as well. So, I think so much of this refractive surgery is an art. It's really, we use guidelines as kind of guardrails to know what we can and cannot do. But then so much of the excellence, I think, that like Dr. Mazen, Dr. Hussam have in their patients is knowing when to go outside the guidelines because that patient is unusual or different.
Yes.
I think that's those are the things that we learn with time and age and gray hair, that you find mistakes. I find my own mistakes along the way, and each mistake or each situation I learn so much from, and I think, oh, now I know I shouldn't do it like that in that case. And so much of that hopefully is what we learn in these types of interactive webinars.
Thank you, Bonnie. Actually, we are learning from you. Are you still using the anterior chamber, Phakic IOL, or no more?
Well, no, we still are. I think that the
very science
and less. Yes, the demand is less and less. Some of it is financial in the country. I think refractive surgery in general, whether it's LASIK or Phakic IOLs, the demand is much lower. I think people are becoming more tolerant of having to wear spectacles or contact lenses because of that. there was also some bad press and bad publicity about refractive surgery with the FDA. And you probably have heard about it. There was a newscaster in a town, and she had LASIK, and then she ended up later committing suicide because of depression. But one of the reasons that she claimed in her letter when she committed suicide was she was having chronic pain after refractive surgery. And even though I think every refractive surgeon you talk to knows that that's not what's going to lead to suicide, that type of bad press in the US have really decreased the desire to have any type of refractive surgery. So I know this is not part of what we're talking about in terms of the medical specifics, but those are factors that come into play when we talk about what patients want nowadays.
Okay, Bonnie, thank you. But what about the incision, the preferred incision for both Dr. Mazen and Dr. Bonnie? Yeah, let's first. Bonnie, yeah?
So the preferred incision, so if it's anterior, so like the artisan, it would be temporal. And in terms of the ICL, it really, I like to look at the eye, whether it's a proptotic eye or deep sulcus, and what's the best approach to avoid any touch with the lens. So that can vary a bit for me.
Okay, Dr. Mazen, please.
Yeah, for me, temporal always.
In all cases.
Yeah, all cases.
It's more comfortable than the superior or the reverse?
Well, because of course I put a suture, so I will control the astigmatism. So in such cases, I don't care whether the steep axis is with the rule, against the rule. So yeah, but I have to consider the steep. I mean, for example, if it is with the rule astigmatism and my approach is temporal, I'm going to increase because I'm approaching the flat axis. So in this case, I'm going to tighten the suture more. So yes, like this, but usually my approach is temporal.
Yeah, temporal and put stitch to control, but don't change your position.
Yes.
Dr. Akram?
The temporal approach is the preferable one to me. As regard the rotation of the lens, to avoid iris chafing and iris dispersion pigment.
Yeah, okay. Okay, about myself, I shifted now to the superior incision, especially if the steep axis on the superior. But if there is a high astigmatism, with the steep axis on the temporal axis, I will place my incision temporally. But if there is a neglected degrees of astigmatism, I will put it superiorly because it's more comfortable to my hands. Actually, if I am planning to do iridectomy, it will much easier to do it superiorly from the main incision than the under incision, because I'm always not putting stitches. It's sutureless all the time, so I'm keeping the incision on the superior axis. Otherwise, if there's high degree of astigmatism of 1.5 or 2, I will put it on the steep axis anywhere. The question here about the
Could I ask a question?
Yeah, okay.
Dr. Mazen, the AC depth 2.8 millimeter, this is a cutoff number?
Yeah, for me it is.
If I have the narrower angle, can I do a peripheral iridectomy in addition to the hole in the center of the lens to guard against closed angle glaucoma?
Yeah. Now, let me say that I consider two parameters, the anterior chamber depth and the anterior chamber angle.
Yeah.
Together, they must be above the limits for me, together, not one of them. Okay, so the angle should be more than 30 the anterior chamber depth should be more than 2.8. If one of them is not like this, then I don't do. In refractive surgery, I am like this. I'm very strict. I always put guidelines and I follow. If it's out of my guidelines, I don't do, because it is elective surgery. The refractive surgery is elective.
Yes.
Now, I agree with you. If the anterior chamber depth is good, but the angle between 24 and 30,
yeah,
yes, still you can do, and but you have to do peripheral iridotomy and two holes. You have to do 2 holes, okay? Even if the ICL is with a central hole, all right? But let me ask you, if you have an angle which is, for example, 21 or 22, and the anterior chamber is 2.8, do you still do phakic ICL?
no.
Yeah. So we are talking about the gray zone then.
Yeah.
For me, I always avoid.
Yeah, okay. Actually, I think that it's a brave cutoff point. 2.8 it's just a brave one, because 2.8 is still narrow and anterior chamber.
Yeah.
Actually, 2.9 or 3, I prefer to be within 2.9 or 3, but after this meeting, I will consider 2.8. But actually, I didn't do beyond the 2.9, especially if the patient is a myopic one, not a hyperopic one, with a good intraocular pressure. We have to consider the intraocular pressure in this parameters. So I will ask you about the intraocular pressure measurement and follow-up after surgery. Do you give the patients after surgery anti-glaucoma for a time, or what to do? Dr. Mazen, starting with you.
Yeah, of course. I will give the patient for at least 1 week. Then I will consider stopping it, even if I do the PI. Not because of the fear of blockage, but because of the inflammation that may happen, because it's an intraocular procedure.
Any residual visco material, so
yeah,
may increase.
Exactly. Yeah.
Okay, and starting tapering, gradual removal or abrupt removal?
No, after 1 week, if the pressure is within the normal range, then I stop it. Then I see the patient within maybe 2 to 3 days to check the pressure, and like this.
What about the preferred substance? Which one of the anti-glaucoma, dorzolamide, the alpha-2 agonist, or which one? Or all?
I usually use the alpha-GAN.
The alpha-GAN, this is it was the second question. What was the role of the alpha-2 agonists after the phakic IL?
Well, let me say that I avoid the prostaglandin because it is intraocular surgery. So I don't want to increase the inflammation. And I avoid any inhibitors, okay?
Yes.
Because they affect the endothelium, okay? Yeah, so we have the alpha-GAN or the timolol. That's it. Beta blockers or the alpha agonist.
Oh, about the other substance effects on the endothelium, it's study-based or just observations?
Well, very good question. Now, regarding the, you mean the inhibitors on the endothelium? No, I don't think that I read that somewhere, but maybe it is like personal contacts with other colleagues, something like this.
Yeah, okay. It's the work experience, you mean. But I read or I heard about the effect of the alpha-2 agonists after the phakic IL on the pupil itself, the pupil or the night meiosis to decrease the haze. Is it true? Is it true or not?
To decrease the haze?
Halos.
Sorry, the night halos. Excuse me. I had a presentation about the haze 2 days ago, so it's haze.
Okay. So yeah, the alpha GAN has
the
an
halos.
effect. Yes,
Yeah.
exactly. The alpha GAN has an effect on the pupil. It constricts the pupil, yes, and it reduces the halos. But of course, I'm not going to give the alpha GAN forever to the patient if he's going to suffer from the halos.
Even if you have a patient which is who is satisfied with the ICL, there is no other problems with it. But actually, the only problem with her is the night halos.
Okay, now I will ask her, when do you feel these halos? Most of them, maybe 99% of them, when we drive at night. It's very simple. Switch on the light inside the car and drive. The pupil will constrict naturally and the problem will be solved without using the alpha GAN. This is what I tell my patients.
Okay, perfect solution. Thank you very much for this information. Dr. Bonnie, what about your opinion in last questions about the...
That's a great suggestion, by the way. I've never heard that. And I'm going to use that even for my multifocal IOL patients who have glare.
Exactly.
I'm going to suggest that. Thank you. That's a great suggestion. In terms of the drops, we usually use an oral, the acetazolamide, so Diamox orally after surgery on the patients. I think some of that we're just treating ourselves and we're worried that there's a spike in pressure in the first 24 hours. And so we tend to give everyone, if they don't have a sulfa allergy, some oral Diamox as they leave the post-op area. And then we'll check the pressure the next day. If I'm worried that there's some still leftover OVD, pressure seems a little high, then my choice is also brimonidine, which is alpha GAN. I tend to use that for any post-op or post-laser, even if it's a YAG laser, an LPI. So any type of post-inflammatory, post-surgical spike in pressure, I think the studies have shown that brimonidine alpha GAN is the best agent. I agree, I do not use prostaglandin analogs just because of the increase of inflammation and the increased risk of CME associated with the prostaglandin. So that's one of the ones we avoid. If I have to use something that will, besides the brimonidine, sometimes their pressure is really high, then we'll go on to the beta blockers and even the carbonic anhydrase inhibitor sometimes if we have to use those. But yeah, I agree, that's my similar approach too.
Okay, thank you very much. Dr. Akram, you have more questions?
Dr. Mazen, did you consider exchange or even removal of the ICL because of intolerable halos? I have a patient, one patient like this, intolerable halos.
Actually, I haven't had any patient suffering from halos, intractable halos, no. By the way, I did extraction just very rarely in just a couple of cases, okay, just because of glaucoma. Yeah, but just because of glaucoma, which was not responding to the medications. There are very, very few cases.
So the glaucoma patients are not candidate for the phakic IOLs, right?
Of course.
Even controlled?
Yeah, even how to open the eye, put foreign body inside, expose the eye to inflammation, and it's an elective surgery. No, of course not. I'm not going to do this for glaucoma people.
Okay, sir. Actually, until I collect the other questions from the participants, you can go, sir, for the. You told me that you have studies to discuss about, or after that, yeah.
No, I said the second part, which is the refractive lens exchange, after we finish the phakic IOL.
Okay. Thank you, Dr. Mazen, for this very informative and basic and guiding presentation, and the addressing of all questions about which are commonly asked from ourselves and other colleagues about the phakic IOLs. So it's my so now we have to go to the strategies to decrease the post-operative surprises with my dear guest speaker, Dr. Bonnie Henderson. Please, Dr. Bonnie, I will let you to share your screen now.
All right, thank you very much. And
Not at all.
Yep,
Yeah.
and the host has to enable screen.
I enabled you now. Right
Okay,
now.
great. Thank you.
Not at all.
All right. And can you see my screen now?
Yes.
Yes.
Wonderful. So first of all, thank you again for inviting me to join this illustrious panel. And it's always fun to do this. And I wish we could all be in person together, but I think this is the next best thing. So thank you very much. I wanted to focus this talk on strategies to decrease the refractive surprises. And regardless of whether we consider ourselves a refractive surgeon or a cataract surgeon, I think we all hate refractive surprises, no matter what type of lens we're using. So I tried to put together a talk so that hopefully we can decrease them altogether as well. These are my financial disclosures. And I separated the talk into, that's what the patient said about the contact lenses. So of course I was surprised and she was surprised. So I just used that example as just, to show how important it is to make sure that the measurements are correct. So the sources of error can be from incorrect measurements, calculations, and sometimes we put the wrong lens in the wrong eye. If it's a toric lens, it's the orientation. And of course, difficult eyes for difficult calculations. So previous corneal refractive surgery, if it's a long eye or a short eye, and the irregular corneas, those can all lead to a refractive surprise. So there's a saying that says garbage in is garbage out. So we know that the measurements going in have to be as perfect and as pristine as possible in order to get the best possible outcome. So, I know hopefully this is common sense, but make sure that all the preoperative measurements are done before any ocular drops are given. It seems like common sense, but I can tell you that I practice in a large group with about 35 ophthalmologists, and I'm probably one of the only doctors who actually do this, which I do measurements before the drops. Almost all the other cataract surgeons have the patients have their drops and their dilating drops and their proparacaine drops, and then they send the patients for measurements. So I think that it's more common than not. And so I do think I stress this point that it is really important to do the measurements on an untouched eye. And so, change around the flow in your office to allow that to occur. Contact lenses, they have to be out before the testing, obviously during the testing, but also even before. So the rule of thumb is usually 2 weeks for soft contact lenses and then 1 month per decade of use for rigid gas permeable lenses. So some of these patients have to be out of their RGPs for 4 months, 5 months. It's a really long time, but I think it's appropriate. And usually you test every month. So I bring them back every month. I repeat the measurements and I compare them. And if there's been a significant change in the Ks or the biometry, then I wait another month and I bring them back and I repeat the measurements again until I have 2 measurements in a row that are stable. And then third is to treat the ocular surface. So look for ocular surface disease. This is a common one. In this picture, I don't think anyone would miss this anterior basement membrane dystrophy, but sometimes it's much more subtle. I've missed it myself. I was concentrating too much on the cataract and I've missed very subtle ABMD. And I still remember a patient where I put in a toric in a patient. And even though this was earlier on where I realized that the K measurements were different in my non-contact biometry compared to my auto Ks compared to my topography, but I kind of chose one of them and put in a toric lens and it was wrong. And the reason is because the corneal surface was irregular. So remember to look really carefully at the corneal surface, especially when your K measurements are not consistent amongst all the different modalities, the diagnostic tools. We know ocular surface disease is really, really common, and there are reports that up to 60 to 80% of cataract surgery patients have asymptomatic ocular surface disease, so it's quite common. Dry eyes and ocular surface disorders, they're really one of the major causes of disappointing outcomes. So patients may be unhappy with their outcome because of the dry eyes. Fortunately, we now have lots of new machines to test for dry eyes. So you can look at the meibomian glands. You can actually look to see what the tear breakup time is, the quality, the tear lake measurements. You can look at the anatomical structure of the glands. So all of these machines were not available even 10 years ago. So we have much more technology at use now that we can use to really assess the ocular surface. And then fourth is to make sure that we have good, accurate determination of the corneal astigmatism, not just the anterior, but obviously the posterior, and then, you know, the topography and the axial length. For the sources of astigmatism, traditionally, we've always looked at the anterior cornea and the lens, and we really didn't think much, we didn't really know much about the posterior cornea, other sources of astigmatism, even the sclera. But fortunately, to Doug Koch's work and Lee Wang, they really educated us about the posterior corneal astigmatism. And, you know, there are some patients who have a significant amount. So if you kind of average it all out, we know that if you only look at the anterior cornea and you ignore the posterior cornea, in the patients with the rule astigmatism, we're overcorrecting by about half a diopter. And in the patients with against the rule, we're undercorrecting by about a third diopter, and that it does change with age. So we have to think about the posterior cornea. Fortunately, most of the modern formulas now, like the Barrett formula, already include a fudge factor for the posterior corneal astigmatism. And if you're using any of the newer calculators, whether it's for the Acrosoft or the Johnson & Johnson Technis toric lenses, all of their calculators already include this factor for the posterior corneal astigmatism, as well as, you know, ASCRS or the APA-CRS websites. They also include those factors too, so we don't have to do that mathematical gymnastics in our head anymore. Intraoperatively, we want to make sure we do everything as perfectly as possible. Besides having as perfect a possible surgery, we want to make sure that we're marking the eye if we're using a toric lens. So we know that people do cyclorotate. So make sure you mark the reference points while the patient is upright. So you can either mark it manually or with a handheld instrument, or you can now use the digital systems like the Varian, where you can have machines, or the Callisto, that you can follow the iris details and mark them and follow it digitally on the operating room table. In terms of centration for multifocal, EDOF, trifocal, all those lenses, the centration is really important. So it's important to have the patient under topical anesthesia so they can actually fixate on the microscope light. So after you've implanted the lens, have them look at the microscope light and align the center of the optic with the light reflex. Don't go by the pupillary center or the limbal center. It's really based on their optical center. So that's a really important point. And then I like to use intraoperative aberrometry. I do think it's one more tool that we can use to make sure that we have the power of the lens correct, the astigmatism correct, the axis aligned. And so it's another way to confirm that we're not going to have a refractive surprise. Now, postoperatively, if you do end up with a refractive surprise, number one, repeat all the measurements, make sure that you're trying to figure out where the error came from. If it's an astigmatism correcting lens, is it in the right position? Is it the right power? And then is the eye centered with the pupillary axis, the optical axis? If it's a toric lens, we can use a website that John Bernal and David Harden put together called astigmatismfix.com. It's a free website, and you just input the refractive error, the power of the toric, and the axis location, and the type of toric, and then it gives you the suggestion of rotation and what the expected refraction is. This is just a screenshot of using that website if you haven't used it before. Very easy to use. Again, you just input all the information that they ask you to input, and then it tells you where the ideal position is, how far to rotate it, and what residual astigmatism you're going to have after that rotation. Another way to assess whether or not there's residual astigmatism is to use something like the NIDEC OPD3, which is a screenshot here. There is a particular screen called the toric summary, and what you do is you dilate the pupil and you retroilluminate the image, and you can see on this image that you can see the toric marks, and on top of the image, the machine will overlay your keratometry measurements. So it will tell you where your steep axis is, which is that red line, and it'll tell you where your toric lens is and how far off the rotation is. So in this particular example, it shows that I'm 37 degrees off the landmark of this steep axis. So it tells me where I should rotate the lens if I'm going to go back in and rotate the toric lens. If you looked at the peer-reviewed literature about toric lenses, this is one of the more recent reports. Again, this is by John Berdal and David Harden, the creators of the astigmatismfix.com. And what they did was they looked at all their data that's been inputted into their website, so a huge number of cases, and they found that there's certain factors that cause more rotation of a toric lens. So if it's a longer axial length, if it's an incorrect capsule rectus size or centration, if there's retained OVD, or if there's an abrupt change in IOP, like the wound collapses, those are all risk factors of rotating of a toric lens. And they also found that certain brands rotate less, like the Acrosoft material tends to be a little stickier and a little gummier. So in summary, remember the preoperative measurements are really, really important. Optimize that ocular surface, do lots of different types of measurements to look at all the measurements of your cornea and the axial length. The IOL calculations are really, really important. So if it's a corneal refractive patient, use something like the ASCRS website. Again, that's for free. And it can tell you what power of the lens to put in, whether it's myopic LASIK or hyperopic LASIK. Spend some time making sure that the eye is marked properly, the toric lens is aligned properly, and if there's a residual refractive error for the astigmatism, try to assess where the lens is, whether it rotated, and then if it's an IOL exchange because the power is off, I do think using something like intraoperative aberrometry is very useful. Okay, so I will stop there and bring it back to Dr. Hossam, and we can discuss if you like.
Okay, Dr. Bonnie, thank you for this nice presentation, which is full of data about the all possible causes for refractive surprises. And let me to ask you about what's the kind of refractive surprises you have faced in your life practice in the ICL, and what was the solution for each?
Sure. So not just any particular lens, I think it really, that can be answered for any lens. So, you know, some of it has to do with the common problems, such as the ocular surface. That's always one of them. So dry eyes, I found that the keratometry measurements are off, and that will lead to even, you know, half a diopter or a diopter of surprise. And if it's a refractive IOL, whether it's phakic or non-phakic refractive IOL, and the patients are paying out of pocket for an elective procedure, one diopter refractive surprise is usually not acceptable to the patient. They're very unhappy. So that's really one of the most common is dry eyes and the wrong keratometry measurements. Another common is the refractive. Right,
okay.
Go ahead.
Okay, but actually I know that the -1 diopter residual error, it's not with the fixed effects, not with the similar effects on all patients. We may have a patient with -1, 1.5, and actually this patient can see well and can see good for him, for his life, and for his. So I think they judge the personality of the patient. What about the realistic expectation? What about your conversation to your patient before going to surgery?
Mm-hmm.
Are you giving your patient a guarantee for 20/20 vision?
I say only Dr. Hossam Ziada in Egypt is allowed to give a perfect 20/20 guarantee.
No.
No,
okay, you can send your patient. Don't worry. You can send.
No, I think what you bring up is actually one of the most important parts of this whole conversation is really the pre-operative discussion and consent. And with any type of refractive procedure, I think it's really important to have realistic expectations. So I always try to tell patients that, you know, of course, the goal is to get them to be more spectacle independent. But I usually tell them that most likely they're still going to need glasses for some distances, no matter what, whether it's phakic or, you know, the lens exchange. Either way, I always try to set up the expectation they're still going to need glasses sometimes. So, you know, I don't want them to be disappointed that they will be completely able to throw away all their glasses. So it's, you know, I wish every patient was realistic. I wish every patient listened to what we said. But I think in experience, we know that most patients probably only heard about 10% of what we said, maybe 20%, and they walk away missing about 80% of the discussion. And unfortunately, you know, it's something that's, no matter what country you're in, I think that's probably true across the board. What is your experience?
My experience is actually the same. Always we are promising the patient to see well, see the best corrected visual acuity for him. But actually, I have to say to my patient that we may get more or less of diffraction after the surgery, but it will be corrected after with the glasses for some time for the fine vision, for the near work, and so. But we never give the patient the promise of 20/20 patient, because we don't know what could happen after that, because of the cornea response to the incision, to the healing of the incision, is different from one patient to another one, for one cornea to another. The cobbling effect of the cornea is always surprising to all of us. But I didn't face, up till now, I didn't face a patient who was far away from the expected range of vision, because this conversation preoperatively. If I got the patient the promise to get 20/20 vision, he will ask me about that after. But if I got him a promise of 85 or 90% correction, and he got more, he will be happier. But let me ask you: did you get a patient with far away, surprising refractive from the expected?
Sure. You know, I think that over time, you know, we definitely have had a few refractive surprises that were really large. You know, some of it is human error. You know, I had a colleague who put in the wrong lens, so they had a 7 diopter refractive surprise because the wrong lens power was placed. You know, that's obviously a clear error, but the fortunate thing is that's just a lens exchange. So even though it is another surgery, that can be solved easily. There are more difficult situations where I find that the patient's refractive outcome, it changes in the first few months. That's, I think, most difficult. So I've had cases where I don't know why they have a refractive outcome. You know, you repeat all the measurements. I can't figure out why they have this surprise. And then, you know, a month later, it's different. So I recently had a patient who had previous myopic LASIK, had cataract surgery, so had a lens out and put in a lens, and he ended up minus 1.5, which is unusual because normally refractive surprise for a myopic LASIK, you have a hyperopic surprise, but he was a myopic 1.5, and very surprising. I couldn't figure out why. And then over the next month, it regressed and he was back to plano. So I don't know why. The lens looked like it was proper. It didn't look like it was vaulted forward. There was really no obvious reason. So, you know, there are some strange situations that I just don't understand.
Yeah. Okay. What about the ICL implantation in keratoconic cornea?
Mm-hmm. Ooh, you know what? I have not done an ICL in a keratoconic cornea. I'm not brave enough to do that. Maybe Dr. Mazen has
Yeah.
Maybe he can explain.
Okay, Dr. Mazen. Dr. Mazen, I will unmute him first. Dr. Mazen?
Yeah.
Yeah, okay, we were talking about the ICL in keratoconic patients.
Keratoconus, yes.
Yeah.
I'm very conservative in this. I did few cases. First of all, there must be a logic difference between the incorrect and best correct visual acuity.
Yes.
So, which means that the keratoconus is mild to moderate, not severe, because in severe cases, maybe the incorrect is 0.2 and the best correct is 0.3. So this is not reasonable to open the eye and put toric IOL, and then I get 0.3 or 0.4. So there must be a reasonable. The second thing, the best correct visual acuity should be good, which means more than 0.6. So the patient will get benefit of it. The third thing is reasonable refractive error. Okay.
Yeah.
And always the lens will be toric, because it is, or not always, let's say in most cases, because there are some cases with small astigmatism but high sphere. But in most cases, the opposite is the true. So I have to be very precise in the sizing to avoid any rotation of the ICL.
Yeah.
Because if it is toric and already the patient is suffering from high order aberrations, and if the lens will rotate, then this will create intractable symptoms. I have to be careful about the axis where I should, the axis of the toric lens, okay?
It's terrible. It's terrible in such patients, I think.
Yeah, exactly. So in general, if I want to implant toric IOL for keratoconus patient, the keratoconus should be mild to moderate, not severe one. And I always tell the patient that this is to improve your vision, but not to solve the whole problem. So you may need contact lens after, you may need, for example, glasses after. Yeah.
Yes. Okay. Okay.
What's the time? Sorry, Dr. Hussein.
Okay.
What's the time between cross-linking Dr. Mazen and putting the toric ICL? 6 months, 1 year?
Yeah. Now it should be 1 year. It should be, because the K readings continue changing even after 6 months. But we can say that after 6 months, if you feel that the K readings are stable, you can go for that. But usually it should be 1 year.
1 year.
Yeah.
Okay, Dr. Bonnie, actually we all the time, we are considering the anterior corneal astigmatism. But really from different centers, I found that the posterior corneal astigmatism may be of an impact on the results of the post-operative fraction after, even insignificant, despite the posterior corneal astigmatism is so little amount, but it is still with impact on the post-operative refractive results after surgery. Are you usually putting the posterior corneal astigmatism in the calculation, or which degree you may consider?
So I am considering it, and I used to, before the formulas were updated, used to actually add half a diopter, 0.3 diopters, or take away a half or 0.3 based on whether it's with the rule or against the rule. But now all I have to do is use one of the newer formulas, like I said, the Ascris website or the Toric on the Acrosoft or the J&J Technis. All of those now use the Barrett Toric calculator, which already included a factor for the posterior corneal astigmatism. So although, it's just an average amount, and there are, because it's an average, there's always a bell curve. So some patients they have less posterior corneal astigmatism, some patients have more. So it's never an absolute guarantee that the posterior corneal astigmatism amount that we're putting into the calculation is going to be accurate. It's really just a guess. One of the ways I think to make it more accurate is to do intraoperative aberrometry, because that's actually taking a reading once you're on the table of that particular eye that includes the posterior and the anterior corneal astigmatism and the induced flattening of the corneal incision. And so those I think are a little bit more accurate. It's not a perfect machine either. So there's regression, and as the cornea heals, what happens with that amount of flattening that occurred intraoperatively. So there's lots of pros and cons. Nothing is perfect. And so, I think making sure, to your point, that the patients understand that we're trying to get them to a good place. We can't guarantee that they're going to get to a perfect place. But I usually use the phrase that we like to make their life more independent of their glasses, but it doesn't necessarily mean that they are going to be able to be glasses free. So, posterior corneal astigmatism is a small factor most of the time. Honestly, it's usually very, very tiny, but in some cases, it's significant.
Okay, nice. But when you prepare your patient, what amount of astigmatism you would consider to put a toric IOL?
So if the patient has with the rule astigmatism, usually it's about 0.75 or more. If they have against the rule, even about half a diopter, I'm considering, especially if I'm going to put in some type of refractive lens. So if they're getting a monofocal lens and they don't care that much about wearing glasses or not, or it's not a phakic IOL, then I'm less concerned. But if it's someone who is
actually, I mean the toric ICL. I said IL. I mean the toric ICL. Yeah.
The toric ICL. So that obviously is different because the patient is looking for a refractive outcome. So very, very different situation. Usually is going to be always a younger patient. So I think even about the half a diopter is really kind of the cutoff point where half a diopter or less, I think people can accept that and it should be okay.
What about the subjective refraction? I'm
sorry, say that again?
I'm asking about the subjective refraction. Is a guide for that? I may get a patient with -1 cylinder, which would be insignificant in refraction, subjective refraction. When I add -1 to the trial, the change is somewhat insignificant. In other patient, it's so significant. So I can consider the subjective then the amount itself, the number.
Are you talking about pre-op or post-op?
Yeah,
So every patient is different. So in some patients, especially the axis of the astigmatism, I think if the axis is with the rule and it's vertical, they don't notice it as much. But if it's oblique, I think they tend to notice it more. So that could be why there's a difference in the amount of how patients are bothered by the amount of astigmatism. And some people are just more easygoing. I think that some people like the fact that they have a little bit of astigmatism and they gives them a little bit more intermediate distance vision. And so they're okay with it.
Okay, but actually I may think in the correction of this -1 up to -1.25 diopters of astigmatism by my incision. It may be, actually the study which I have conducted about the correction of astigmatism by corneal incision, it gave me a result of 0.8 diopter correction with a corneal incision of 3 millimeter wide. So actually in the ICL, I made my incision. I usually make my incision 3.2 millimeter to implant it easily without resistance. So it may correct up to -1 even diopter. So you may consider that.
Yeah, it's possible. The other issue with a corneal incision and astigmatism correction is that how long will that flattening last? That's the question, because each patient, depending on the thickness of the cornea, the age, the location of the incision, they're all variables on how much astigmatism correction you're going to get with a corneal incision. And then 1 month post-op is different than 6 months, which is different than 1 year. So there's so many variables with corneal astigmatism that it's so hard to know. It's hard to have a hard and fast rule about that.
Okay, in your presentation, did you talk about the pupil, the mesopic pupil diameter?
Not necessarily, no. I'm happy to discuss that, and I probably don't care as much about the pupil size as some other people. So, it depends on what we're talking about. So if we're talking about the pupil size of multifocal EDOF lenses, or are you talking about pupil size of a phakic IOL?
The ICL, yeah, in the ICL.
For the ICL, yeah. I think it's very patient dependent about the pupil size. What is your experience? Are you more concerned about the pupil size? What are your parameters?
And the pupil size is so important, especially if it's away from the normal, the accepted range, which is 4.6 millimeter. So if it's more than 6, I will think about, because I have a very little but bad experience about the large pupil. With a patient, she is suffering up till today from the lens at night, the phakic IOL at night, because of the wide mesopic pupil. And this is the first one to implant with one of wide pupil, which was 7 millimeter in mesopic condition. And it was the last to do. So I didn't try it again because really
Annoying patient.
yeah, so annoying patient. She is a small lady. She is the wife of my friend. A lot of familial problems, but actually I respect the mesopic pupil diameter, and I recommend my practice to be less than to be less than 5 millimeter. What's your experience, Dr. Mazen, if you are here? Dr. Mazen? On mute.
Muted, yeah.
Yeah. Okay, sir.
Yes, Dr. Hussam, tell me.
Yeah, okay. About the mesopic pupil diameter in the ICL, it's considered. What's your rules in that?
Okay, now usually the phakic IOL, when the higher the power, then the smaller the optical part of the ICL. All right?
Yes.
It will be smaller.
Yes.
So the mesopic pupil will affect. But in the usual range that we use for the ICL, the mesopic pupil is does not affect unless it is more than, for example, the mesopic pupil is more than 6 millimeter. All right?
Yes.
Yeah. So
I told Bonnie I told Bonnie now about a case of 7 millimeter. So
yeah, exactly.
She's annoyed and annoying me all the time.
Yeah.
I'm thinking now to expand the IOL. It's one of the indications which we'll talk about. Okay, also the toric ICL, which degree will astigmatism, and how to judge to put the toric ICL or to put spherical one with correction of astigmatism on the plane of cornea.
Okay. No. Why to do 2 procedures
Excuse
to the
me?
patient? Why to do 2 procedures to the patient? Why to do spherical one and to do top up on the cornea? Why two?
No, I will not do 2 procedures, just one. I want to place my incision on the steep meridian to correct the small degree of astigmatism. Yes.
Yeah, of course, this depends on the surgically induced astigmatism, depends on the surgeon's factor. Most surgeons are between 0.5 and 1. For me, it is 0.5, for example. So if, for example, if the patient has 1 diopter of astigmatism, corneal astigmatism, because my SIA is 0.5, so the remaining will be 0.5, for example. So it doesn't worth to put toric IOL for 0.5. Usually, if the remaining more than 0.75, I will put toric IOL. If the remaining after the deduction of the SIA.
Yeah. Okay. Thank you. But the pupil diameter, you will do not beyond 6 millimeter diameter.
Beyond 6.
Yeah.
Yeah, beyond 6. Yes, beyond 6.
What about you, Dr. Akram? Akram?
I'd like
you have a cases?
to ask.
Yeah. You have a cases with wide pupil, implanted ICL, and cases of that like that?
Not beyond 6 millimeter.
Yeah, okay. You have a question for Dr. Mazen or Dr. Bonnie?
Yes. I have a question to Dr. Bonnie. I'd like to ask about the cataract in a keratoconic patient. how to lessen the post-operative surprise, refractive surprise.
The cataract surgery phaco?
Yeah.
Yeah.
Okay.
Mm-hmm. How to deal with it, how to treat it, is that the question? I'm sorry,
How to decrease the surprises, the post-operative refractive surprises in patient with keratoconus and the cataract at the same time.
Sure, sure. So I think there's two different scenarios with keratoconic patients. The first situation is where the patient is dependent on a contact lens to see well. So they really depend on the physical compression of the cornea, compared to the other category where patients are able to function with a spectacle to decrease their astigmatism. Even though they have keratoconus, they're okay with the spectacle correction. I think that is a very different situation. So the easy one is where the patient uses spectacles. So what they're doing is they're using glasses, which is a regular way to correct their astigmatism, to correct their irregular cornea, but they're sufficiently happy with the quality of vision. In those patients, I think the refractive surprises are more easily tolerable, because if they come up with a refractive surprise, a pair of glasses should be fine. The patients who are more difficult is the first category, where they rely on the rigid gas permeable contact lens. Because of that compression, the actual post-op corneal configuration is a little bit more unpredictable, because they've always had flattened corneas. So in those particular patients, I think that they have to either tell us whether they would like to consider still wearing a rigid gas permeable contact lens after surgery. And if so, then those patients, I would not put in astigmatism correction in the eye with a toric lens. So in those patients, I would just try to correct the sphere as perfectly as possible, and then rely on their contact lens to flatten their cornea, and then solve any residual refractive error. So those are the most difficult patients. And ideally, if they can stay out of their contact lenses for months and months to make sure that the corneas are in their final resting position, then we can predict a little bit more carefully.
But actually, Bonnie, let me just say that the correction behind the cornea is different than the correction in front of it.
Correct.
The contact lens will remove the irregularities of the cornea, so you will get a much better vision. But actually, putting the IL behind the irregular cornea will suffer from the irregular refraction of the light rays before going to the IL. So it will.
Agreed.
So I think it will be a different story. You think so?
Well, I still think that the patients who are wearing spectacles preoperatively and they're okay with the quality of the vision, they're going to be okay with the post-op refraction, versus the people who are wearing the contact lenses, just that extra variable. Just like you said, the contact lenses flatten the anterior, but it's not correcting the posterior.
Yeah.
What happens afterwards is really more unpredictable. So, I think in that situation, the pre-op counseling is even more important in that patient. They really have to understand that we're going to try the best we can with all the best instruments that we have, but they may end up with a refractive surprise. They might need an IOL exchange. They might need to, if you even put in a toric lens, which I still think it's okay to put in a toric lens, they might need to have a rotation. It might change over time. They just need to know that, their state is a little bit more unpredictable.
Yeah. Okay. Thank you, dear. This what makes me to think and putting the ICL, spherical ICL in case of keratoconus, and consider the intracorneal ring segments to correct the corneal astigmatism. In my opinion, in my short practice, the ICR implantation will correct the corneal astigmatism if you choose. If you choose the ideal segments, thickness, and arc length for it, it will be much better than putting a toric ICL. This ICL may correct the spherical error somewhat more accurate than the astigmatic correction in such cases. So let me to ask you the last question before going to the procedure, the video for the procedure itself. if you have a residual error, either spherical or astigmatic error after ICL, will you consider the surface ablation for that? And this question for you and for Dr. Mazen too.
Sure. So I definitely prefer surface ablation. It depends on how much error there is, whether, if it's a gigantic error, it was the wrong power, then I'm going to replace it. But if it's, half a diopter, 0.75, 1 diopter even, I think a surface ablation is reasonable for that.
We may suppose that you have a refractive error of which is not too big to explant or exchange the ICL, either minus 1.5 sphere or cylinder, and it's effective. It's subjectively influencing the visual acuity of this patient. Will you consider the corneal laser vision correction, Dr. Bonnie and Dr. Mazen?
Again, it depends on the person, depends on the corneal health. It depends on a lot of factors. I usually try to talk them into being happy with a myopic surprise if it's -1, and especially if they're close to 40 or so. I usually tell them, that's great. You're not going to need reading glasses. That's wonderful. So, I try to push them into keeping it because the less surgery, the better. But if it's a small amount and they're really unhappy and it's their dominant eye especially, then I think it's reasonable. I think that's better than going in and traumatically trying to exchange the lens if possible, as long as our corneas are healthy.
Okay, perfect. Thank you, dear. What about you, sir?
Dr. Hussam?
Yes?
Yeah, I agree with Bonnie. Actually, it depends on patient satisfaction and whether the residual refractive error in the dominant or non-dominant eye, because if it is in the non-dominant eye, most patients will tolerate that. Yeah.
Okay, thank you, sir. Yes, Dr. Akram?
Let's go to the refractive lens exchange. It is
yes.
Too late.
Yes, it's too late in Dubai.
Actually, I was about.
And too early in Boston.
Actually, it is 1 a.m. in Dubai, and I have duty at 9. So, if you allow me to present my presentation very quickly, then I have to go to sleep.
And no, sir. You have to take your time. Okay, now, Dr. Mazen, please, I allowed you to share your screen to give us very valuable tips about the refractive lens exchange, which is commonly performed. Let's say that it's commonly performed.
You are telling this to me that it is commonly done. Actually, I hate it.
because it's related to the financial or the money-wise status of the patients. But actually, I disagree. If the patient is unable to do the right one, to wait on the glasses and the contact lenses. Please, sir, start.
Great. Now, clear lens extraction, as you said, it is done. Let's say talk about scientific part, not financial part. So it is done for extreme cases when we cannot do LASIK, when we cannot do or PRK, for example, and when the parameters inside the eye are not suitable for phakic IOL. So in this case, we may go for clear lens extraction and do monovision or mini monovision. This is one of the solutions, or clear lens extraction and implantation of premium lenses, such as multifocals, trifocals, or EDOF lenses. And the talk about the premium lenses will be similar as if we are talking about cataract surgery and premium lenses. So the workup for clear lens extraction and mini monovision or monovision, I consider the age, of course. For the age, I don't do clear lens extraction when the patient is below 45. By the way, I don't do the surgery at all, but in general, these are my rules. Not below 45 years old. For the refractive error, it should be done for plus, not for minus, especially if the plus is above 4 diopters and LASIK is not suitable. Regarding the posterior astigmatism should be considered, of course, should be considered for the toric IOL calculation. As I said before, that we have to consider that total corneal refractive power, 3 millimeters, as I showed a slide before. We have to determine the non-dominant eye, and we have to do the tolerance test in the clinic in order to see whether the patient will tolerate a difference of 175 to 1.5, 125, 1 or less, because there are, let's say, a range of difference or monovision and mini monovision. Some patients may tolerate up to 2 diopters difference. Some patients may tolerate just 0.5 difference. So we have to be sure which difference the patient will be tolerant to. Then we have to study corneal tomography and wavefront. Now, here I have to show you some beautiful slides. First of all, when the cornea is a parabola, when the Q value is minus 0.53, there will be no spherical aberration. So this is called the eagle eye, okay? There will be no spherical aberration at all. When the Q value is more positive, for example, minus 0.2, there will be positive spherical aberrations. And whenever it is more negative, for example, minus 1, there will be negative spherical aberration. Now, the cornea is in the positive side, okay? It ranges between 0 to 0.55. But the average in the average population is plus 0.27, plus minus 1 standard deviation, okay? So this is the average of the positive spherical aberration induced by the cornea, the human cornea. Now, what is the depth of focus? Now, let's assume that this old gentleman is reading a book and he is using glasses and he doesn't have any accommodation. There will be something called the depth of focus, which means that this gentleman can move the book forward and backward within a range, a specific range, and he can still see clearly. We call this depth of focus. So he can still see clearly in spite of not using accommodation, all right? We call this depth of focus. Now, the depth of focus to spherical aberration. When there is no spherical aberration, the image on the retina will be very sharp. And the image in the brain will be very sharp as well. But this has a disadvantage, which is if the object moves, then there will be a severe blurriness of the image on the retina and on the brain. That's because there is no spherical aberration. There is no depth of focus, all right? Now, if we say that this patient has some spherical aberration, it means that there will be some blurriness of the image on the retina, but the brain can, let's say, adapt by neural adaptation, and the image can be seen clearly as long as the spherical aberration is within the tolerable range. Now, what is the advantage of this? The advantage is when the object moves backward or forward, the image on the retina will not blur so much, and the image in the brain will stay very clear. Unless the object goes beyond this range, then the image in the brain will start blurring. Now, if the spherical aberration increases, and in this case, of course, the image in the brain will start blurring, and whenever the spherical aberration exceeds the threshold and becomes toxic, then the blurring of vision will be intolerable. Now, let's divide this on the slide that I've just shown you. So we can say that the spherical aberration can be divided or classified into into non-toxic and toxic. It is within the normal range whenever it is between 0 and 0.35 plus or minus. It is non-toxic whenever it is between 0.35 and 0.6, and it is toxic whenever it exceeds 0.6. This is on the positive side and similarly on the negative side. All right. Now, as I said, the human cornea is on the positive side, but the ocular aberration is not on the positive side, completely just like the human cornea. Why is that? Because the human crystalline lens is on the negative side. So there will be like a compensation, and the resultant ocular spherical aberration is between 0 and plus 0.1 microns at age of 19 years. Why age of 19 years? This is the age of perfect vision. Very sharp vision, okay, but there is no depth of focus. And of course, this young age, they do not need depth of focus because their accommodation is very strong, all right? But with age, the human crystalline lens starts moving to the positive side, which increases the ocular spherical aberration to the positive side, which is a good thing to have because this will increase the depth of focus. Okay, now, what is the relationship between the depth of focus and spherical aberration? When the spherical aberration is 0, there will be no depth of focus. But when the spherical aberration increases, then the depth of focus will increase as well, on the positive and the negative side as well. However, we have to put in mind that the myopic treatment pushes the spherical aberrations towards positive because the cornea becomes oblate, while the hyperopic treatment push the spherical aberration towards negative because the cornea becomes prolate and hyperprolate. All right, but of course, this is not for free. This will affect the quality of vision. The quality of vision is perfect and contrast sensitivity is highest when there is no depth of focus and when the spherical aberration is 0. And the contrast sensitivity will go down with the increase of spherical aberration and therefore the increase of depth of focus. Okay, so we have to put in mind that the hyperopic treatment will increase depth of focus and the myopic treatment will increase depth of focus as well. But the quality of depth of focus and the quality of vision is much better on the negative side. So people having, for example, after hypermetropia, the depth of focus, people, they have depth of focus and quality of vision better than that induced by myopic treatment. By this, I come to this algorithm, which I built. I call this algorithm the practical subjective IOL selection, or the PSIS algorithm. Of course, in the market, there are different types of lenses based on the spherical aberrations and based on whether they are premium or not. Now, the spherical IOL, the old or the traditional spherical IOL, it induces positive spherical aberration. There is aspheric IOL with 0 spherical aberration. There is aspheric IOL with negative spherical aberration, and this type has different brand names which they differ by the amount of negative spherical aberration they induce. So because there is no financial interest, I'm not going to mention the brand names and everyone how much spherical aberration it induces, but they are, if you go to the internet, you can find out that. But so we have different, let's say, a good range of negative spherical aberration induced by such aspheric IOLs. And of course, we have the premium IOLs, trifocal, multifocal, and EDOF. Okay, so the PSIS algorithm depends on the amount and type of the high order aberrations, the amount and type of the spherical aberration. I mean by the amount, the magnitude, of course, and the type, whether it is positive or negative, in addition to the demands of the patient, the desired depth of focus, whether the patient is interested of having depth of focus or not, or if the patient is interested of having a perfect quality of vision. Because as I said before, depth of focus means less quality of vision and vice versa. So how to start with the PSIS algorithm? Of course, we have to evaluate the high order aberrations and we have to evaluate the spherical aberration. To evaluate the high order aberrations and spherical aberrations, for example, if I have a pentacam, I have to be sure that I am using the maximum diameter 6 millimeter, as you see. I click on the pyramid, I click on the wavefront aberration cornea for the both surfaces, not only, I'm not checking only one surface. And I have to click on the N3, the third order, which includes the vertical and horizontal comma, vertical and horizontal trefoil, in addition to click the N4 M0, which is the spherical aberration. So these 5 high order aberrations are the main aberrations that should be studied. And of course, the computer will show us the RMS of those within the blue ellipse, as you see, the 0.249 in this case. And this one should be 0.35 microns and less to be normal, otherwise it's abnormal. And at the same time, the computer will show us the spherical aberration as an individual high order aberration. In this case, it is 0.242. Okay. Now, if you don't have the pentacam and you have the Cyrus, for example, or the MS39, unfortunately, you cannot click or you cannot make them as a group like in the pentacam. It just shows you the amount of high order aberrations in total from 0 to N6. So it shows the full amount of high order aberrations, not only the third order and the spherical aberration. And it shows you the comma separately. It shows you the spherical aberration separately, and it shows you the residual, which is the trefoil. Okay, now regarding the desired depth of focus and the desired quality of vision, these are subjective things that we have to discuss with the patient before we choose. Now let us start with the PSIS algorithm. If the high order aberrations are normal, it means that they are less than 0.35 microns, equals or less. Then if the patient is interested in depth of focus, it is critical for him, then we have to use premium IOLs because the high order aberrations are normal. But if the patient is interested in sharp quality of vision, then we have to compensate for the spherical aberrations that the cornea has, because don't forget that we are removing the crystalline lens. So the main structure that will affect the ocular ocular spherical aberration is the cornea. So we have to take care of, or to read the corneal high order aberrations and spherical aberration. So we have to use minus or negative spherical aberration if the cornea has positive, and if the cornea is around 0, we can use the 0 spherical aberration. We have to put in mind that our target is to achieve ocular spherical aberration, which is plus 0.1 microns, because it has been found that this will give better quality of vision, better than when the spherical aberration is 0. So the target is like this. For example, if the patient has corneal spherical aberration of 0.3, for example, then I have to implant a negative spherical aberration IOL which is minus 0.2 in order to achieve plus 0.1 as a target. Now, if the high order aberrations are abnormal on account of other high order aberrations, like on the account of coma, trefoil, and so on, then in this case, I have to use the IOL with zero spherical aberration. I cannot change the spherical aberration because I'm going to induce more high order aberrations. I have to maintain what the patient has. And if the high order aberrations are abnormal based on on account of the spherical aberration, then I'm going to move to the next slide. So now the patient has abnormal higher order aberrations on the account of abnormal spherical aberration. In this case, if the patient had previous hyperopic laser vision correction, so what do you expect? We expect that the patient has minus spherical aberration because of the prior hyperopic laser vision correction. In this case, if the patient has toxic negative spherical aberration, I have to compensate anyhow. I don't care about whether the patient is interested in depth of focus or not, because they don't tolerate. So in this case, I have to implant the positive spherical aberration, which is the spheric, not aspheric, it is spheric, the traditional spheric lens. Now, if the calibration is negative and not focus, but I have to ask the patient if he is interested in depth of focus, then I have to maintain negative spherical aberration by implanting zero spherical aberration. Otherwise, if he is interested in image quality rather than depth of focus, I have to compensate for the negative spherical aberration that he has by implanting the positive spherical aberration IOL. Now, if the eye is virgin and the patient has toxic spherical aberration, in this case, of course, I have to compensate, because usually the virgin eye, non-operated eye, the cornea has positive spherical aberration. So I have to compensate, and I have to target to be a plus 0.1, as I mentioned before. Now, if the virgin eye does not have toxic, it has only non-toxic spherical aberration, and the patient is interested in depth of focus, I have to maintain the non-toxic. And if he is interested in quality of vision, in this case, I have to compensate for the positive, by default, to the positive spherical aberration by implanting minus, negative spherical aberration IOL, and don't forget the target. Now, if the patient has a prior myopic laser vision correction, again, if they are toxic, I don't care about what patient's demands. I have to compensate by implanting minus or negative spherical aberration IOL, targeting the plus 0.1 microns. If the spherical aberrations are positive and non-toxic, in this case, I have to consider patient's demands. If the depth of focus is critical, then I have to maintain it. And if the quality of vision is critical, then I have to compensate for it, targeting the plus 0.1 microns. So by this, I come to the number 7, which is specular microscopy, as I mentioned before, no need to repeat. And for the number 8, the sulcus to sulcus, white to white, scleral spur to scleral spur. Now we come to the clear lens extraction and premium IOLs. We have to take care of ocular surface. Of course, as Bonnie said before, that ocular surface is mandatory for all types of refractive surgery, but actually in premium IOLs, special care. We have to do all tests that can detect the severity of dry eye, for example, ocular surface diseases, blepharitis, whatever, because this will affect too much the quality of vision, K readings, measurements, whatever, after the operation. And for the age, clear lens extraction should not be done if the patient age is below 45. For the refractive error, again, it should be reasonable. Now, regarding the pupil, it's very important this is for the ocular surface disease. Of course, we have to put staining, different types of staining to evaluate the surface. Now, regarding the pupil, there are two issues: the shape of the pupil and the mesopic pupil size. Now, regarding the shape, of course, these shapes are contraindication for premium IOL implantation. If the pupil is very small, if the pupil is very large, so the pupil should be between, the mesopic pupil should be between 2 and 6, not below 2 and not larger than 6 millimeters. Now, this is how we measure the pupil. Usually, I measure the scotopic, mesopic, photopic, and dynamic. It's very important to measure the dynamic as well. Now, the computer will display, of course, this is, let's say it is infrared-based pupillometer. It is built in the MS-39. So it shows me, and in Cyrus as well. It is available in Cyrus. So it shows me the scotopic, mesopic, and photopic. In addition, I have to study the dynamic. I have to study what happens to the pupil movement, whether it is a large movement, whereas there is 0.1 millimeter. So the center of the pupil during the dynamic, it moves just within 0.1 millimeters, which is very good. If it moves larger than this, for example, up to 0.3, 0.4, 0.5 millimeters, then it means that maybe if in the photopic circumstances, then the pupil will be centered with the trifocal or EDOF, the center of the trifocal or the EDOF. But whenever it dilates, the center of the pupil will be shifted, and then this will cause some dysphotopsia. So if the dynamic measurement shows a wide range, then as well this may be a contraindication. I don't have a cutoff value to say that whether it is more than 0.2 or we come to angle kappa should be less than 0.5 meter. Otherwise, this will cause dysphotopsia. Regarding the total corneal refractive power, it is mandatory to take the measurements of K readings and the measurement of the astigmatism by the total corneal refractive power. We cannot depend on the SIM case. And why? Because if we implant, for example, trifocal or EDOF, which are not toric, in cases of more than 0.75 diopters, the patient will suffer from dysphotopsia. So the issue here is not that, okay, there is residual astigmatism and we can treat later. The issue is not residual astigmatism. The issue is the patient will suffer from dysphotopsia. So we have to consider the astigmatism in our treatment. Corneal tomography and wavefront. Of course, we do not implant premium lenses in such cases. I do not implant after myopic. I do not implant after astigmatic treatment. I do not implant after hyperopic treatment. Now, it's very important to consider the high order aberrations, the total high order aberrations, not the spherical aberration here. It is the total high order aberration, which should be less than 0.35 if I'm using the pentacam. But because the Cyrus takes into consideration all order, so we may say that up to 0.4 microns, 45 microns, it can be acceptable. Normal and the correlations. Now look at this case. If we apply the parameters that we all of us use to laser vision correction or not, we will see that everything is fine. Even it may appear that there is superior steep, but if you look at two opposite points, you will is not having high order aberration. So it is not enough to study the topography. We have to see the premium IOLs. Now I can show you some examples. This is a case of normal total on account of spherical aberration, as you see. So if I'm going to do laser vision correction, I can go for optimized. I can put phakic IOL. If I'm putting monofocal, clear lens extraction with monofocal lens, then zero spherical aberration if the patient is interested in depth of focus, or negative spherical aberration IOL if the patient is interested in sharp vision. And I can use the premium IOL as well because the total RMS is normal. This is another example. The patient has high order aberrations. The spherical aberration is very low. So this high order aberration is on account of vertical trefoil and horizontal coma, as you see. So in this case, I look at the symptoms. If the patient is symptomatic, then I have to use the topo-guided or wavefront-guided treatment, not the optimized. I can use the phakic IOL, as I said before. If I'm implanting the monofocal, then I must not change the spherical aberration. I don't care about whether the patient is need sharp vision or depth of focus. I have to put zero spherical aberration. And of course, the premium IOLs are contraindicated in such a case. Now, this is another example. The total high order aberration is high. The spherical aberration is moderately abnormal. The vertical trefoil is abnormal. The horizontal trefoil is abnormal. So as you see, there is a mixture of such high order aberrations. And the patient is asymptomatic. In this case, I'm going to use the optimized. I'm not going to change the native high order aberrations of the patient. I can do the optimized laser vision correction. I can put the phakic IOL. If I'm using the monofocal, then the zero spherical aberration, because the spherical aberration is relatively high and I can maintain it to maintain the depth of focus. Otherwise, I have to compensate for it in order to get sharper vision. But trifocal and EDOF are contraindicated. Now, this is another example using the Cyrus. The total refraction, the total high order aberrations high. The spherical aberration is low. The patient has symptoms. In this case, I have to go for topo-guided or wavefront guided. Phakic IOL are okay. For the monofocal, I have to put zero spherical aberration. This is example number 5. The high order aberrations are abnormal. The spherical aberration is high. So the abnormal high order aberrations are on account of the spherical aberrations. So in this case, the patient is symptomatic, so I can use the optimized. I don't change the native spherical aberration of the patient by laser vision. I don't use, the wavefront guided or the topography guided. I can put the phakic IOL. For the monofocal, I consider the demands of the patient. If the patient would like to maintain the depth of focus aberration, otherwise negative spherical aberration. Focal are contraindicated because the total RMS is high. Example number 6, the total high order aberration is 0.52. The spherical aberration is very high. So as you see, it is on account of the spherical aberration symptoms. In this case, I have to go for topo guided or did, and phakic IOL are allowed. Monofocal can be implant. Otherwise, it should be negative spherical aberration. But or the tri are not allowed premium in general because the high order aberrations are high. This is the last example. The total is okay, the spherical is small, and so I will go for sure for the optimized. I can go for the phakic IOL. I can go for the monofocal zero spherical aberration to maintain this small amount of the spherical aberration. Otherwise, I can put negative in order to target the plus 0.1 to achieve better or sharper vision. And I can use the premium IOL, and that's it. Thank you very much.
Thank you, sir, Dr. Mazen Sinjab, for this wonderful presentation. It's really a very rich and guiding presentation. Actually, the clear lens extraction look now muchly different with your guidelines. Because the malpractice in the field of the clear lens extraction is usually away from the guidelines, so I hate it or I disagree with it. But if we are following these guidelines, respecting the high order operations, respecting the all parameters inside the eye, also respecting the early or the premature presbyopia for that patient, especially in young patients less than 45, it will be helpful for the patient. But let me ask you a last question because of your time. If you have a patient with 45 years old, and this patient is candidate for both clear lens extraction and the ICL, what will you prefer to do?
What is the refraction of the patient?
The refraction minus 12, minus 13 is away from LASIK and
Yeah.
fem to LASIK and fem smile.
Yeah. Well, I know that it is a tricky question. Now, of course, 45, some surgeons, some famous surgeons who I respect, they consider the cutoff age for the phakic IOL or the ICL is 50. So I may follow this, and I will tell the patient maybe after 5 years, you will start developing cataract. I think this is much better than doing the clear lens extraction to this patient, because 45 is still young, okay?
Yeah.
And yeah, and he is still away from the age of cataract. And he has high myopia, which puts the retina at risk of retinal detachment. So no, I don't go for clear lens extraction. 45, yes, I do phakic IOL. Now, you may ask me if he is 50, the same question.
Yeah.
Yeah, in this case, I may change my mind. I may go more to clear lens extraction.
Yeah. Okay. Actually, the age of cataract onset is not known for every patient. Yeah. So let me ask the question in a different way. If you have a patient with 55 or approaching 60s, and the diffraction is below the 10, around -6, -8, will you consider the laser vision correction in such patient if everything is okay?
Yeah. Believe or not, I did LASIK for a lady who was 70.
70 years, okay.
She had very clear lens.
Yeah.
And she was keen to do that. She came to me, she was from Iraq, and she came to me very educated, and she said, I want LASIK.
Yeah.
70.
Yeah. It's so it's so risky. It's a very brave step, but actually I did a case was 61 for a man, and his wife was 57, and they are okay up till now. 4 years ago, they are with clear lens and seeing 20/20 up till now. So you are now encouraging me and all of us to consider if all parameters are okay. About the fundoscopic workup for that patient is not added, but it has to be considered very, very, very essentially to check the retinal periphery. If you find any degeneration like the lattice or the non-significant retinal degeneration.
Yeah. I consider laser treatment for the retina. I mean laser retinopexy.
Yes.
Just if I have tears,
Okay.
if I have free holes only. If the holes are within lattice, or if they are surrounded by atrophy and pigmentation, I don't do laser for them. In addition, I don't do the 360 degrees prophylactic treatment because it exposes the patient to giant tear retinal detachment in the future. There is a strong correlation between giant tear retinal detachment and previous 360 degrees prophylactic treatment. So it is an old fashioned.
Yes.
I don't do laser to all generations, just if there is free hole,
yeah,
or there is tear. Now that's it.
Yes, yes, nice. This is the rule which I am following. The 6 years or more, 10 years ago, there was the era of retinopexy 360, but nowadays it's not more performant.
Yeah.
Finally, I will finish with this question. On the opposite direction, if you have a lady of 20 years
Mm-hmm.
and she is not candidate for laser vision correction with a very high myopia, and
Mm-hmm.
she is also not candidate for the phakic IOLs, will you go for clear lens extraction with the premium IOL?
No, I don't touch.
Because of what? What's the difference in such a state condition?
High myopia, retinal detachment. She is still young. She can use contact lenses. Why to put her at risk?
If you find that the IOL implantation is the only way, I said a lady, she is a lady, not a man.
Yeah.
So we have some social problems with the thick glasses and the contact lens with complications. So I will put the IOL, the ICL, if the anterior chamber depth is okay, but if not okay, to do the clear lens and giving her or putting inside her eye the premium IOL to correct the presbyopia.
No, I don't do this.
Yeah,
there is a lot of things. First of all, the fibrosis that may happen, decentration of the premium lens, opacification of the posterior capsule, the need of YAG laser later, the risk of retinal detachment, the high incidence of dysphotopsia in young ages when we put the premium lenses, and this is scientifically based, published.
Yeah.
So I don't do that such contact lenses, and that's it. Maybe she will go to a colleague who is braver than me.
Okay. Thank you, sir. The discussion with the experts is non-ending. There are a lot of questions, but I will ask my colleagues if they have any more questions about this topic. Please to send them to me on my Facebook page or on the YouTube channel Hussam Ziada iTube to address them with Dr. Mazen later, because of the sake of time. Dr. Mazen, thank you very much. Dr. Bonnie, unfortunately, she has now another webinar on the other side, so she logged out. Thank you very much for your time.
Thank you very much.
And your time and your efforts are very
pleasure.
So appreciated. Thank you, sir.
Pleasure.
And
thank you. Goodbye.
Thank you again. Alaikum salam wa rahmatullah. And thank you all. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam wa rahmatullahi wa barakatuh.
Yes. Stop share, sir.
I have to stop from my side.
Yes, I can end the meeting.